Noswaith Croeso. Good evening and welcome everyone. It's my great pleasure to be able to introduce this evening's talk on the impact of COVID-19 on people's mental health, to be delivered by my colleague, Professor Jon Bisson of Cardiff University. Jon is a practicing psychiatrist and professor in psychiatry at Cardiff University. He is the mental health speciality lead for research in Wales and was formerly Director of Health and Care Research Wales. Jon developed his interest in post-traumatic stress disorder, PTSD, during his time as a psychiatrist in the British Army. He has conducted numerous studies on trauma, including 2 widely cited randomized controlled trials of early psychological interventions following traumatic events, and 5 Cochrane systematic reviews in the traumatic stress field. He was co-chair of the UK's first PTSD NICE guideline development group and chairs the Treatment Guidelines Committee of the International Society for Traumatic Stress Studies. He has developed and continues to lead Cardiff University's Traumatic Stress Research Group. Jon has also developed Veterans NHS Wales, a service for those who have served in the armed forces and who may be experiencing mental health difficulties. Jon, a huge number of us will have found this pandemic traumatic and stressful in many different ways. We look forward to hearing your insights and advice. Incidentally, I know that you're keen to take questions this evening, so I'd encourage our audience to use the Q&A function to type in their questions to Jon. Jon, diolch yn fawr iawn. Thank you very much.
Great, many thanks, James, and hello to everybody. Let me just share my screen with you, and then hopefully that will allow you to see my presentation. Good, so hopefully now everybody can see my presentation. Is that right? Hopefully, James, if you can just sort of put on your video and give me the thumbs up just to double check on that.
Yeah, we can see you and hear
Perfect.
you, Jon.
Thank you. So what we're going to talk about today then is mental health and the COVID-19 pandemic. And I'm going to start off by sort of talking generally really about the types of stressors that people might be experiencing with the COVID-19 pandemic, looking a bit at general population studies with a particular focus on the United Kingdom. And then in the second half of my talk, I'm going to focus much more on what's happening within the National Centre for Mental Health within Cardiff University and the research that we're doing. So, as I'm sure all of us are aware from our own personal experiences, the psychosocial stressors we're being confronted with as a result of COVID-19 are really multifaceted and multiple. There are direct ones, which thankfully the majority of us will not have had direct experience of, although an increasing number will have had experience of, such as hospitalization as a direct result of suffering from COVID-19 ourselves, experiencing residual symptoms, having apparently recovered but being left with some ongoing difficulties relating to COVID-19, or very sadly, some of us will be faced with COVID-19 related bereavement. So colleagues, relatives who've died as a direct result of COVID-19 and some of the difficulties associated with that. There are also the very real indirect stressors associated with COVID-19. So for example, social isolation is something that a lot of us have had to endure to a greater or lesser degree during the pandemic. Financial hardship is something that some people will have had to endure. And I think that's one of the ones that we're expecting to see more of as time goes on, with people being economically impacted by the COVID-19 situation. And then, of course, changing government policies, probably something that we're all aware of and is quite stressful to us all at the moment, wondering what is going to happen next, whether the current situation is going to remain the same. We've probably got one eye on the rate of cases at the moment, another on whether we'll be able to see families or not over Christmas. And so there's multiple different stressors that we're facing. And those are just some examples, really. I mean, there are lots of other different stressors that people are facing, and I'm sure that we could all make our own personal list, which I'll go on to discuss in a bit more detail later on. What about reactions? Well, right at the beginning of the pandemic, several of us were asked and interviewed about what the types of psychosocial reaction might be to the COVID-19 pandemic. I mean, I've always personally felt that we shouldn't be focusing just on potential more negative or distressing reactions to the crisis, but there also may be some positive things that come out. And that's certainly well recognized in the literature following various stressors. So positive things might be hope, sense of societal and community cohesion. And I certainly think in the first few months of the pandemic, we saw some real good examples of that. I mean, probably several of us remember standing outside on Thursday evenings, clapping the NHS and other key workers. And clearly that was a really good example of strong societal and community cohesion. My sense, speaking to people, and probably from personal experience as well, is that that kind of phase has fallen off a bit as things have dragged out and gone on for perhaps longer than we were initially expecting. And the second wave has certainly been, very difficult for a lot of us to contend with, and the ongoing restrictions. Of course, the emergence of a vaccination and perhaps getting more used to the situation and seeing some light at the end of the tunnel has perhaps given us a bit of a lift as well. Another thing that's widely spoken about following traumatic events is post-traumatic growth. And post-traumatic growth is something that can occur to individuals who are traumatized, perhaps giving individuals coming through a trauma a different perspective on life. What's really important, what really matters. Is work the be all and end all to everything, for example? And I suspect that several of us have, experienced a degree of post-traumatic growth during the pandemic already, perhaps living our lives in a slightly different way, prioritizing some of the things that we perhaps neglected before. I mean, I certainly on one level found it very helpful not having to commute in and out of Cardiff every morning to work, and work more from home and be a bit more flexible in what I'm doing. Of course, the flip side of the positive side, and the thing that I think we are seeing more prevalent than positive reactions at the moment, so more, if you like, more negative reactions. So the psychological and emotional distress that accompanies a crisis, a stressor such as the COVID-19 pandemic. Common ones that I think we were predicting at the start were the potential for grief, and probably more complicated grief for some people. I mean, I've been very concerned about the stress that having limited numbers of people going to funerals has placed on people. I mean, right at the start, it was worse than that even. And I think some of the rituals that we have relied on really to help us get through some very stressful situations in life have been taken away from us, and there are additional things we've had to confront following the deaths of people who are close to us. And of course, that doesn't just impact COVID-related deaths, that's anybody who's died during the COVID pandemic, I'm sure, has had a different experience of funerals, etc., in the grieving process than they would have done otherwise. Anxiety, depression, traumatic stress symptoms are probably the three commonest groups of symptoms that people have been predicting will occur following the COVID-19 pandemic. And there have been some interesting results from research that's been done to date that I'll present this evening. I also think that it's really important, and when we go to look at some of the figures, to consider, is this a pathological reaction or a normal reaction to an abnormal situation? I mean, a lot of my career has been spent trying to think, how can we try and prevent people developing psychological distress following traumatic events? And I've really become very aware that a lot of people will be distressed following traumatic events, but actually they'll recover very well without the need for formal intervention. And I think one of the things we've got to be very, very careful of is that we make sure that we don't interfere with the normal recovery process that people go through. It's normal to be distressed to certain events, and we shouldn't really be pathologizing the upsets that is normal in a traumatic situation. Of course, some individuals will go on to develop what most of us would classify as a more pathological reaction, and equally, just like not over pathologizing reactions, it's really important not to under pathologize reactions that are pathological, and we need to detect and offer treatment to people that do develop more significant reactions that can be helped by some of the interventions that we've got. And thereby hangs a very difficult challenge really for us as helpers and mental health professionals, as researchers. You know, sort of a holy grail has been, how can we actually detect people appropriately in a minimally invasive manner and then offer them appropriate assessment and treatment. So this is a study that I really like, and I think it's one that should really inform us in our thinking around how to respond to traumatic events or stressful events. This is basically a case series of around about 1,000 people who presented to a trauma hospital in Australia, or trauma hospitals in Australia, following traumatic events that resulted in them needing to be hospitalized for over 24 hours. So most events were things like road traffic accidents, maybe some assaults, maybe some industrial injuries, but the sort of traumatic events that you might come across on trauma wards in hospitals such as the University Hospital of Wales. And this just tracks people's psychological reactions, focusing specifically on symptoms of post-traumatic stress disorder following a traumatic event. And what they found really interestingly was that for one group, at baseline, they're distressed, and then over time, they gradually improve. And by 6 years, they've got residual symptoms. But for a lot of these people, they haven't needed any formal intervention. They gradually recovered over time. The interesting thing with that graph is that if you look at that bar, which I was always brought up when I trained to be a psychiatrist as being the normal reaction following a traumatic event, that accounts for 6% of people. So the vast majority of people involved in traumatic events don't suddenly get distressed and then gradually improve over time. In fact, the trajectories are very varied. The commonest by far, actually, is this resilience trajectory. There's a bit of a reaction at baseline, but not too much if you group everybody together. And then really no real symptoms at any stage over a 6-year period following the traumatic event. So the truth is that humans are very resilient beings. The majority of us will not have marked reactions following the majority of traumatic events. Now, 27% of us will do, and 27% of us will either start off low and then gradually increase. That accounted in this study for 8% of individuals and then recovering after 2 years. For some people, they'll start off low and then just gradually get worse and worse and worse over time. And that worsening trajectory accounted for 10% of people in this study. And then there's a chronic group where individuals start off high and stay high over time, and that accounted for 4%. So as you can see, these trajectories are very different, and don't forget these are grouping 1,000 people into 5 groups. So if I plotted every individual trajectory, you'd have multiple lines that just covered the whole graph, people going up and down, some people going very high, coming down, going up again. And so I've become a real believer in the importance of following the trajectory of people's symptoms over time. If somebody has symptoms and they start to reduce, then for me, we should be thinking that could well be a normal reaction that's going to reduce over time. But it's really important to monitor it, because that individual may then kick up again and perhaps need some intervention at a later date. And these are the sort of educational messages I think we need to be getting out there, so that people that are coming across people, you know, who have been traumatized by the COVID-19 pandemic can actually monitor people appropriately. So what I'm going to do now is to run through a few of the key UK studies that have been performed since the COVID-19 crisis. And I'm going to take a bit of a timeline to this. So the first study that I'm going to mention is this study of Mark Shevlin and colleagues. This was published in the last couple of months, but actually it was a survey that was completed between the 23rd and the 28th of March 2020. So almost coinciding with the very start of lockdown nationally across the United Kingdom. What they did was they found a sample of 2025 UK adults. And I think one of the important things, I'm no epidemiologist, but actually I think we've all become kind of, armchair epidemiologists as a result of the COVID-19 pandemic. And we're being presented with a lot of epidemiological data that we're being expected to sort of process and interpret in some ways. And what I'm going to go through today with the different studies I'm looking at is just to describe a little bit about some of the differences in the methodological approaches that the different groups have taken, because it's really important to consider that, because you are definitely, with the studies I'm going to describe, comparing apples with pears, if you like, rather than apples with apples, because they've all got slightly different methodologies, and so you can't directly compare one with another. This study, one of the key strengths of this study was that it used what's called a representative quota sample. So this was actually 2025 UK adults from a massive panel from a commercial company in the UK who have panels of people who are representative of the whole population. So what they did was they made sure that the proportion of males and females was roughly the same as occurs in the population as a whole. So in this study, 52% of participants were female, which is pretty representative of the national level. In this study, 91% of participants were white, which is pretty representative of ethnicity across the United Kingdom as a whole. Clearly, you can use various methods to look at ethnicity, and I'll go on to discuss some different things there. What it also did was got representation in terms of household income. So actually, those 2025 people represented the cross-section of different household incomes, which, as we know, is massively unequal across the United Kingdom, but it was representative in the study of those incomes. What they didn't do, but one would suspect by using the sampling that they did, they got a reasonably representative sample, was look at the actual educational attainment levels of the individuals. And in this study, 44% of individuals had a degree or higher, which is probably a bit above the national average as a whole, but we are a well-educated society. So 44% had the equivalent of a degree or higher, and 49% were in full-time employment. So what they used was something called the PHQ-9. This is the Patient Health Questionnaire 9-item version. And this is a good measure of depression. It's a very well validated, it's been shown across different populations to measure symptoms of depression. One of the things you have to be a bit careful about with the PHQ-9 is using it in people who are very physically unwell. It can give slightly falsely elevated rates in people who are physically unwell. The GAD-7 is the Generalized Anxiety Disorder 7-item scale, and the ITQ is the International Trauma Questionnaire, which itself has 18 items to it. So it's a 9-item scale, a 7-item scale, and an 18-item scale. What the ITQ does when you use it like this is it assumes that you're answering for a traumatic event that would be a traumatic event of the nature that would qualify for a diagnosis of post-traumatic stress disorder. And I'll go on to talk a little bit about that later on, but it's really important to take that into account. So in this study, as you can see, the blue bar showed that around 22% of people scored above a cutoff for depression. 22% of people scored above a cutoff for anxiety, and around about 17% of people scored above a cutoff for post-traumatic stress disorder. And that's asking people about symptoms in relation to the COVID-19 pandemic. Now, what they did was they tried to look at studies that were similar, not the same study, but similar in their methodologies. So for anxiety and depression, they took a study from the northwest of England that looked at individuals with a degree, well, certainly with lower household incomes on average than the individuals in this study overall. So it was a more economically deprived study. And they found in that group, they had levels of 17% of depression, this is pre-COVID, and 13% for anxiety using the same scales. So the thing we have to remember straight away is that actually there's quite a high baseline of anxiety and depression in the population as a whole, even if you haven't got the COVID pandemic going on. So what they found was that the levels increased by about 50% for anxiety and maybe by about 20% for depression. Interestingly, using a representative sample for the PTSD questions, there was actually more PTSD apparently in society as a whole before COVID than people reported having to their experience of COVID-19 overall. What they did in common with other studies, they looked at associations with negative outcomes, sorry for my jumping, and they found that younger age, having children at home, and the level of personal risk of catching COVID that you felt were all associated with worse outcomes across the board. They found that low or loss of income and pre-existing health conditions were associated with anxiety and depression, but not with raised levels of post-traumatic stress disorder symptoms. The second study used a slightly different methodology. So this is another UK general population COVID-19 study, and this was a survey completed between the 23rd and the 30th of April, so a month after we went into lockdown. 17,452 UK adults, so very good sample size. And these were all individuals that had already taken part in the UK household longitudinal panel within 2 years of the COVID pandemic. So for these big studies, like these longitudinal studies, there's often a panel of people. I mean, I think there's about 45,000 people on this panel that are quizzed every so often about their level of mental health and other things, non-mental health related questions. And they used a questionnaire called the GHQ-12, the General Health Questionnaire 12. So immediately we're comparing apples with pears. We're comparing the GHQ-12, which is an overall measure of distress, rather than looking specifically at anxiety, depression, or post-traumatic stress disorder. But nevertheless, the results weren't that different. So in this sample, we found about 18% of people were positive for mental distress in 2018 or 19, so pre-COVID, and around about 27% post-COVID. So another increase of what, 30%, 40%, that sort of a level. And again, they found associations, this time younger age, female, and having young children at home. So different ways of looking at it, but we're starting to pick up some common patterns coming out of the different studies being done. The third study is, going backwards, the third study is one from Kwong et al. And this is a study using the Avon longitudinal study of parents and children. Some of you may be familiar with this study in the audience, but this is a study that's looked at a birth cohort. So in other words, back 28 years ago, every child who was born in Bristol at that time, their parents were asked if they would be willing for them and their children to be involved in a longitudinal study. So in other words, would you be willing to answer questionnaires every so often? And they've done a brilliant job at following people up over the last 28 years. And so 2,973 UK adults with a mean age of 28, who were actually the children that were born 28 years ago, and their parents got them involved in that study all those years ago, took part in this. And these were also individuals who'd completed the same questionnaires before COVID-19. Again, they used slightly different questionnaires, although the GAD-7 was a common anxiety scale that we use. For mood, they used the short mood and feelings questionnaire, and they introduced the Warwick-Edinburgh mental wellbeing scale to look at wellbeing overall. And as you can see in this study, they got slightly different results in that they found a reduction in depression. A reduction in depression from pre-COVID levels of 24% down to post-COVID levels at about 17%. But for anxiety, they found the reverse. They found anxiety amongst the 28-year-old population to be much more prevalent, if you like, as a result of COVID than depression was, so massively in excess of what you would expect to see given the levels before COVID. Just to say and to point out, most surveys like this, longitudinally, what you would expect to see over time is a slight reduction in your symptoms as you get a bit older over time. So you would tend to expect that depression scale to go down a bit over time, you know, so it's not saying that people are feeling much happier because of COVID-19 there. And then low well-being, well, there certainly was a slight increase in the number of people that were feeling overall that their well-being was worse than it was before COVID. And again, they looked at associations. The reason I've got an asterisk there is that when they started to look at associations, they included the parents of the children as well, whose mean age was more like 60 or 58. And they also included 4,000 people who've been taking part in a longitudinal general health survey in Scotland. The issue was that they hadn't got pre-data on those groups. They only had this comparable pre-data on the 28-year-olds. But what they found was, looking at the groups as a whole, that associations with self-reported poorer outcome following COVID were being infected by COVID-19 itself, living alone, having no access to a garden, being of younger age, female, again, some really common themes coming up here, economic adversity, and pre-existing health conditions. So again, you'll see some patterns, some new candidate associations coming in, and you know, things like no access to garden, that's not been uniformly asked about overall studies. So we don't know whether it would have been associated in other studies, but you probably remember around lockdown, there was a lot of a sense that people who had space around them would find it easier to cope with lockdown if you didn't have good space around you. And then this is the final sort of UK general population study I wanted to mention. So this is a study that was completed in the same way as the other ones, starting back in March, but individuals who took part in it were asked to complete the survey every single week. And so not everybody completed it every week, but the graphs that I'm showing you are individuals who did repeat it on several occasions during that 20-week period that I'm showing you in the graph there. This is the UCL, the University College London study, so it's quite a famous one that's received quite a lot of media attention, and 36.5 UK adults took part in this. One of the interesting things I think about this study is, look, we've got 76% females in this. Compare that to the population average of more like 52%. 70% had a degree or above. And in this one, 5% reported themselves as Black, Asian, or a minority ethnicity. So we're below the actual sort of average levels there. So this sample, when you're interpreting the results, they're not quite representative of the demographics across the United Kingdom as a whole, and it's important to think like that. Good news, they used exactly the same questionnaires as we're seeing coming up on a repeated basis. And very good news, I suppose, is that you can see that actually reported depression rates did go down overall between March and August in those who completed these scales, as did the anxiety scores. The mean levels were about 7.5 and just below 6. National population surveys would come out more with a mean of around about 3 to 4 for those scales. So these are definitely elevated levels compared to what we would expect to see as general population levels. The associations were being female, younger, lower educational attainment, lower income, living alone or with children, pre-existing mental health condition. So again, those 4 different studies I've shown you, they're coming up with very sort of consistent patterns in terms of associations. Now, the reason I'm talking about associations here is because none of these studies can really say that what we're looking at predicts whether you're going to do better or worse. You need to have a different design to your studies to predict whether something is going to do better or worse. They might predict, and they'd certainly be candidates to consider whether they predict poorer outcome or not. But with the methodologies used, we can only talk about associations rather than predictions. So with that information then, what should we be doing? What should we as mental health professionals and other people who like to sort of try and improve the health and well-being of the population be doing? Well, my view is that we should be offering practical, pragmatic support in an empathic manner. I definitely believe that social interventions, community level interventions are going to be really, really important in this. And I think we've seen that as we've gone along. I mean, however we look at it, you know, whatever the government's done, there's been some things that make us feel more positive, more negative. Good communication has been helpful to us, helped us understand some of the difficult decisions that are having to be made. But those sorts of interventions and good communication, I think, have been really, really important in terms of how we react to our situation and the situation that we're in. Trying to do things together, you know, be it sort of having collective Zoom meetings as part of our, you know, university or other workplace scenario, and, you know, supporting each other and seeing each other and having a laugh every so often as best you can over Zoom. Those are really important things, you know, finding ways of supporting one another. I think we do need to be avoiding over medicalisation. We're still in the midst of a stressful situation at the moment. Hopefully we'll come through it sometime next year. We're starting to see some green shoots now, but I definitely don't think that the sort of the 25% plus levels of people who are reporting clinically significant, supposedly levels of depression and anxiety at the moment means that we should be putting 25–30% of everybody on an antidepressant straight away or offering them cognitive behavioural therapy. That's not the way forward here, I don't think. The other thing I think is that by over medicalising situations, you've got to be very mindful that you can be doing harm to people by pathologising, you know, what can be, as I said before, very normal reactions that people are having. That said, again, really important to pick up people that do need additional support and help. And the way I look at it is if people have got severe enduring difficulties that are increasing over time and perhaps really having a negative impact on their functioning, that's the time that I'd be talking about, you know, at least recommending that people talk to somebody, get some form of assessment. And obviously in our health system, then general practitioners are a very good first port of call for that. Collaborative approaches to try and help people, I think, are really important. You know, building on the existing socioeconomic support structures, I've said, I'm sure for a lot of people, things like the furlough scheme have really helped with their mental, you know, health, as well as giving them that practical support straight away. And certainly one of my big predictions personally is that things like depressive symptoms will be as much associated with the consequences of COVID-19, including financial consequences, job consequences, not having a proper structure to life, having to study in different ways than they are to the actual virus per se. Watchful waiting, which I think is what I've been talking about, is key. And then being aware of key signs, knowing some of the signs and symptoms that you would look out for and should start ringing alarm bells to you. You know, if people are saying that they're feeling that life's not worth living, having suicidal thoughts, then clearly those should start alarm bells ringing and, you know, necessitate recommending that people seek further help. And certainly we would be offering treatment for psychiatric disorder and are providing treatment for those individuals who do develop formal disorders. So to put it another way, we're using a pyramid approach. The Interagency Standing Committee is a standing committee of the United Nations, which I've always been very keen with their publications. And if you're after good, practical, pragmatic advice following traumatic events, particularly on a population level, and basically their advice is primarily directed at lower and middle income countries, but I think it's really, really pertinent to us in our country as well, is thinking of this pyramid system where you've got social considerations, which include basic services and security, strengthening community and family support, to focus non-specialized supports, which may be provided by a primary care health doctor, basic emotional and practical support by community workers, support workers, for example, who are looking after more vulnerable groups of people. And then at the tip of the pyramid, you're getting into more specialist services, which might include mental health professionals, for example. Another thing that's been really spoken about with COVID-19, but which there's been a lot less good, well-designed research done on to date. I think it's still a bit too early to be doing that, and there are studies underway, is to think about the neuropsychiatric complications of COVID-19 itself. So we're now not looking at the population as a whole, we're looking at individuals specifically who've been infected by COVID-19. And actually the focus of this sort of research are those who've had more severe physical symptoms overall. So there is efforts to perform UK-wide surveillance. So this is really asking neurologists, psychiatrists, other mental health and other professionals to report through a national surveillance system if they come across people who are having what appear to be unusual reactions, rarer consequences as a direct result of having been infected by COVID-19. I mean, again, I think at this stage it's quite difficult to say it is necessarily, directly as a result of the virus, but nevertheless, they didn't have these conditions before. They've developed them since, and there seems to be an uncanny relationship in terms of timing that may well be connected. So at the time that they published this paper, this is the Baratharaj paper, they'd only done a limited amount of surveillance through to April, May time, and 143 people had been reported on. 31% of those people reported altered mental status, and the commonest thing that was reported was what they described as an unspecified encephalopathy. To you or I, that's probably confusion is a better way of thinking that. So a confused mental state, which is often, what we would call a delirium in another term. So people who are acutely confused is what really is being referred to there as an unspecified encephalopathy. And encephalitis is an infection of the brain where there's some evidence of having an infection of the brain, and would often present with confusion, other symptoms such as perhaps visual hallucinations, but being in quite a confused, disorientated state. A small proportion of people described a new onset psychosis. So almost out of nowhere, they developed what appeared to be a psychosis characterized by hallucinations, hearing things, seeing things, perhaps feeling things, and having delusional beliefs, perhaps being paranoid that people are out to get them or harm them. And then another small proportion of people have developed a dementia-like syndrome. So in other words, where they've got cognitive losses, which are characterized by difficulties with memory. So these are very small numbers of people. The vast majority of people who are affected even severely by COVID-19 don't go on to develop these types of conditions, but nevertheless, a small minority do. More common are sort of milder cognitive and behavioral issues, which have been noted in around about a third of people following intensive care admissions as a result of COVID-19. So perhaps feeling a bit foggy in their thinking is a common description. So kind of a low grade type of a confusion sort of a state, and lethargy, sort of not being their normal selves, definitely noticing that they're different to the person that went into hospital. I mean, personally, I think that's not to be unexpected, really. And the key question is, how long does that last for, and do people recover from that? And really what's been emerging more recently is something called long COVID, which are a wide range of persisting symptoms following COVID-19. I think long COVID, I mean, it's a kind of a media term that's been coined, and it's not really got a helpful definition, and it's probably not a single condition, to be honest. It's probably very heterogeneous and describes a range of different things. Some people have labelled people with symptoms that last for more than 3 weeks, post-acute COVID-19, and for greater than 12 weeks, chronic COVID-19. So we'll probably see those sorts of terms crop up more in the medical literature, certainly in the near future. And as you can see from this list here, the symptoms reported in long COVID are multiple, cough, fatigue, low-grade fever, shortness of breath, GI, gastrointestinal upset, rashes, mental health conditions, memory loss, so lots and lots of different things. And the possible causes are also multiple. So ongoing viremia, still having a viral infection in your blood, is one potential thought. having become reinfected again is another one. Having a problematic immune response or reaction that's caused these vague sort of multiple symptoms that people can get with immune related disorders. Deconditioning, so basically become physically unfit as a result of your COVID infection, is another one. And then mental health factors and social factors. So for example, if you've got a depressive episode, you're much more likely to have these sorts of physical symptoms that may even be part of the depressive illness, or at least exacerbated by the depressive illness, rather than being purely accounted for by physical factors. And the same occurs for social factors. So if you've got major financial difficulties, it can't half feed into your mental and physical symptoms overall. Management, clearly pending further research, is really excluding serious things and treating those and any comorbidities. So for example, if I diagnosed somebody with long COVID and post-traumatic stress disorder, I'd want to treat the post-traumatic stress disorder and see what was left at the end of that. Being pragmatic, sympathetic and holistic in your approach, I think, is really important. Avoiding over-investigation, inappropriate medicalization, considering treating particular symptoms. For example, if somebody just can't sleep, has got marked insomnia, we might consider treating that in its own right, even though we're not quite sure what the underlying cause is. And then there's an ongoing debate really about how best to help people get conditioned again. And certainly for some individual, a graded return to exercise may be helpful, but as several of you are probably aware, in the chronic fatigue syndrome literature at the moment, there's a lot of debate about the role of chronic exercise, So before I go on, let me just pause, take breath, and answer Harry's question, which is, why are there so many people denying the existence of COVID-19 in spite of the scientific evidence added to what is physically happening to the population in terms of death? I mean, Harry, I don't know the answer to that one. I mean, I'd be really interested in yours and other thoughts. To me, there's overwhelming evidence that, COVID-19 is really, really serious. I mean, one thing I do wonder is that I think it's kind of quite a clever virus, in that for some people you can have it and you can have no symptoms at all. And then for others, you get a really, really extreme condition. And actually the majority of people who have it, get away, well, I suppose they do get away, I was going to say, for want of a better word, but with minor illness. And so they don't get severely unwell with it. And I wonder whether that has led to some people, not taking it as perhaps as seriously as they might. I mean, I think in terms of denying, I just can't see that at all. And we, I'm sure several of us have seen some weird and wonderful theories coming up that we find it very difficult to get on with. Also, why are people able to accept the massive numbers of death rates here and around the world and yet raise up in alarm over a single person? Yeah, well, these are really good questions, Harry. Is there some form of mental protection of themselves? I think that's a really good question. I mean, I don't know. And I mean, one of the interesting things, of course, is that we are being shocked by very large numbers of deaths. But when we look at the actual excess mortality rates, they were very high at their worst, or a lot higher than they should be. But now, and in recent times, they've not been as high above that. And I wonder whether that's been to do with that. But I suspect that actually denying that we're going to get a serious condition and thinking that we're going to live through this and, maybe even forever, is probably quite a good defense that we all have against mortality to a degree. How many cases have been recorded so far with long COVID? Well, that's a really good question. I don't know, and I don't think anybody knows that. I mean, things like that surveillance website that I showed you, those were asking people to register that, but I don't think there's any news on exactly how many cases have been recorded. Some of you might know there's something called a post-hospital COVID study going on, which really arose from a study looking at people with respiratory impact, which is clearly a key issue that people with COVID have suffered from. And that, I know, is doing some research looking at other symptoms. And so we should get some clear answers as to how many people may be affected by long COVID who have suffered from COVID that's resulted in hospitalization. How do you think the best way to address vaccine hesitancy is? I think, Ellie, public awareness campaigns, raising awareness, having high profile people, using it and having doses of it, and ultimately having a lot of people who are having it and not reporting problematic effects is going to be a really important thing there. Sarah, have frontline medical staff been assessed for PTSD? They have. There's few studies at the moment in the United Kingdom that have looked at that, but certainly if you look at studies looking at, for example, health workers in China, then you have got excess rates of post-traumatic stress disorder. There's a couple of studies going on. There's a very big one running out of King's that is ongoing at the moment, where medical staff are being assessed for post-traumatic stress disorder. We run something called Helping Healthcare Professionals Wales, and we're not seeing lots of healthcare professionals coming through with post-traumatic stress disorder for treatment to our service, but we don't actually know what the ultimate thing is going to be there. I'm going to take a couple more of these, and then I'm going to have to move forward. I'm sorry, but what do you think the impact of people not being able to achieve what they like to do during lockdown? Well, I think it could be high, actually, anonymous attendee, nice name, because I think that a lot of people have, had a lot of plans scuppered, really. So, I mean, weddings, holidays, etc. I think we've all had multiple things now that we were planning to do, we didn't think would be cancelled and have been cancelled. Perhaps things make people feel pressured to make changes. I don't know. I've started to read articles, for example, about people splitting up as a result of having to live together more on, in the same house all the time compared to before. And Andrew, have there been qualitative studies that have investigated? There are some reports, but there haven't been great ones coming through that I've seen yet. But I know there are more coming through, and a lot of the studies that are being set up at the moment are using mixed methodologies. So keep your eye out on that. I'm really sorry, but I'm going to have to move on. I mean, I will come back to questions, and I'm sure there's a way that we can answer them by typing in and then make things available to everyone. So I'm going to move on now to think about this. Can I just check? Oh yeah, I know what I can do now. Good. I hopefully have got rid of that to everybody, and I can give you a little overview of what we're doing now within the National Centre for Mental Health. So the National Centre for Mental Health is a research centre that's funded by Health and Care Research Wales, a Welsh government body, and Ian Jones, on the top left of my slide as I'm looking at it, is the director of the National Centre for Mental Health. And what we're aiming to do, our post-traumatic stress research is embedded within this, is to develop large populations of people with lived experience of mental health difficulties, and then work with them really to improve the health and well-being of people with mental health difficulties through research, helpfully. We've got a few different work packages, which I won't go in today. And just to say that Bangor University, Swansea University and Cardiff University are all working collaboratively with the National Health Service on this. So what we've done is between June and July to have a survey for people who had already taken part in our NCMH survey. We invited just over 10,000 people with lived experience of mental health difficulties to take part, and just under 3,000 people completed the service in a way that we could analyse their data. We use, as you can see, the GAD-7, the PHQ-9, so some commonality to other studies. And we also use the WHO-5, which is a World Health Organization measure of well-being. Our mean age was just under 45, and we, again, have got predominantly females. So we've got an excess of females to males compared to the population as a whole, 95.1% white, so our ethnicity isn't totally representative of the demographic. And again, we've got quite a high level, 50% of people with degree level or above education. We've got a wide range of different mental health diagnoses, so anxiety, obsessive compulsive disorder, depression. These are figures of people, so you can see around about 2/3 of our sample reported having a diagnosis of depression. just under 500 people reported post-traumatic stress disorder, and lower numbers with bipolar disorder and schizophrenia or psychosis, but nevertheless, quite a number of people, personality disorders, or autism spectrum disorders, and other disorders. So we've got enough people with different disorders to try and look at individual disorders and consider if people who are experiencing those are being affected in different ways to the general population or to people with different types of condition. Our PHQ mean scores were 12.76 and 10. I haven't shown it here, but you might remember when I looked at the score in the big London study, the mean score was more like sort of 6 to 7 for the PHQ-9 and for the GAD-7. So we're finding higher rates of depression and anxiety in our population of people with lived experience of mental health difficulty compared to the population overall. We're also finding reasonably high levels of people who describe poor well-being overall. So that's a rate of around about 2/3 of people described having relatively poor well-being. Don't forget, this isn't comparing pre-COVID, this is just asking people here and now, you know, how are you? So this may or may not be related to COVID-19 as a whole. But what we did do is we asked our population overall, how many of you feel worse since the COVID-19 crisis? And between 50 and 60% answered that they felt worse. Breaking that down a bit, and this is something that interests me a lot, is that around about 10%, so this is the dark blue and the red pie squares, cake pieces, whatever we want to call them, they reported feeling much better since COVID-19. So they reported their mental health having improved significantly since COVID-19. And just as an anecdote, which you can never rely on, but a few people I've seen, some of my patients have reported feeling better since COVID-19 because they're not having to go out as much and they don't feel as exposed, if you like, to the external world, which they find very anxiety provoking within itself. So felt less anxious indoors and it felt more normal because other people aren't going out as well. So that's something that we're planning to investigate further with the data that we're collecting. As you can see, a high proportion of people felt the same, that COVID-19 hadn't made any difference. Of the people that said they felt worse, most felt worse rather than much worse, if you see what I mean. But clearly the majority of people felt negatively impacted by the COVID-19 crisis overall. Factors associated with worse mental health, well, younger age, difficulty accessing mental health services, low income, having your impact affected by COVID-19, worrying about it and the impact of it on you and your relatives, sleeping less than usual, taking substances, and not feeling socially supported by friends and family. So we had a few questions in, but we found it very interesting that the support you receive from friends and family does appear to be a protective factor against suffering from a perceived deterioration in your mental health. I certainly would have predicted that from existing literature, and I think it's an important thing for us to build on when we're thinking about what sort of things we can do to help people that we're concerned may be affected. Clearly, we're seeing several things here that we've seen in some of the other general population surveys I've already mentioned. Diagnoses associated with a worse mental health outcome, well, the majority of them were, but you'll be interested, and I'm sure you can see that bipolar disorder, schizophrenia and psychosis were not associated with worse outcome. Anxiety, depression, eating disorders and traumatic stress disorder, the asterisk on that signifies that they were also associated with self-reported worse outcomes. The other ones were only associated with worse questionnaire scores. So those four groups, the four on the top, appeared to be those groups that seemed to have the worst outcomes directly resulted to COVID-19. And I should say I've got Lewis K et al. In preparation here, and that's just sort of you know, to give appropriate recognition to Katie Lewis, who's really, you know, driven forward the analysis of all of this work and has kindly shared her analyses for me to present with you tonight. We've just completed, hot off the press, a post-traumatic stress disorder survey. So this is asking the same people that we surveyed earlier this year, another survey where we were looking specifically at post-traumatic stress disorder, as well as repeating some of our earlier measures. And what we found here, using the International Trauma Questionnaire that you'll recognise from me talking before, is that around about 40% of individuals surveyed reported at least one aspect of the COVID-19 crisis traumatic. This is perhaps one of you to have a think about tonight or tomorrow. If we asked you, please identify the experience that troubles you most about the COVID-19 crisis, what would it be? That's quite an interesting question. If you're allowed to write down one thing that troubles you most about it. These are the responses of the people we surveyed with lived experience of mental health difficulty. Just generalized worry about the situation was the commonest. Lockdowns and restrictions was the next commonest. Death was the next one, but much lower. Other people not following the rules was a significant concern for about 25 of the people we surveyed. The government's response, news media coverage, having to wear face coverings, being in an at-risk group, financial work worries, being exposed to people at work, and having COVID or suspected COVID. So it's quite interesting, the different range of things. And for those of you interested in post-traumatic stress disorder, and sorry to be a bore on that as I am, most of these things you will recognise aren't really what we would be looking at as traumas in terms of post-traumatic stress disorder, which really are extremely threatening or horrific events or serious events, according to the ICD-11, or actual or threatened death, serious injury, or sexual violence, according to the DSM-5. These are the two classification systems we tend to use in mental health at the moment. There's a lot of debate about what satisfies these criteria or not, but our take is that actually, us all living through the pandemic would not be enough to say that that satisfies the criteria for COVID-19. Really happy to debate that, and that might be a really interesting one for a debate in the future if we start to have debates through these sessions. Our results, well, what we found was that 1% of people had COVID-19 related PTSD if you apply our strict criteria for the trauma. If you widen out the trauma and say that anything somebody reports as traumatic could satisfy the criteria, then 13% of people reported the criteria for post-traumatic stress disorder directly related to a COVID event. If you look at post-traumatic stress disorder to other events, then that rate goes up to 23% for overall, if you're irrespective of what the event is, and 13% if you only include a COVID, a qualifying event according to the classification systems that we use. And just for those really interested in this, complex post-traumatic stress disorder is what we tend to find more commonly. So of the 13%, 11% or 90% of those had complex post-traumatic stress disorder rather than a simpler form. And recognition to Catherine Lewis in this instance, who's done the analyses for this work. So our next steps within the NCMH are to perform further analyses, to perform further COVID-19 surveys. We've got a sleep survey out at the moment. We've got ones planned for eating disorders and obsessive compulsive disorder, and then more will be in the pipeline that will be following our cohort up over time. We're also developing guided self-help interventions for some of the conditions that we feel people will be experiencing that are likely to be exacerbated by their COVID experiences, prolonged grief disorder and complex post-traumatic stress disorder being the key ones here. So I'd just like to say thank you for your attention. I'll leave it to James to decide how we progress with respect to any more questions at the moment, and of course to say a big thank you to the team within National Centre for Mental Health who've been working together, and just to show where I work, but I've not worked, it has to be said, since March of 2020. Thank you very much, Jakob.
Diolch, John. Really fascinating presentation there. We've had some great questions already. I know there are a number of others that have come up as well. Perhaps wait whilst you have a quick scan through those questions. John, can I ask you, how have your patients adapted to maybe having consultations online or by phone as opposed to face-to-face?
No, that's a really good question. And I have found that people have adapted remarkably well. If I'm honest with my work, most of the people that I've seen post-COVID are people that I did not know before COVID, although a handful I have known since COVID. We've used digital platforms such as things like Zoom, but Teams, Attend Anywhere. There are other platforms available, and we've been interviewing people with that. I found it's worked remarkably well, and in fact, for first assessments with a lot of people that I've been seeing as a psychiatrist, several people have fed back to me that they find it more relaxing to speak to somebody if they're in their home environment than having to come into the Hayden Ellis building, try and find a car parking space, battle through the traffic you've got to get into Cardiff before, take 3 bus rides to get to. These are all the practical things that I think we don't talk about. Yeah. So certainly my view is that we should be moving much more to a telehealth environment in the future and being offering people choices. There's only been a couple where I've not really felt that I, as a psychiatrist, have been able to function well in a virtual environment. Of course, I can't do a physical examination, but then again, I'm not regularly doing physical examinations on the people I see. But if I were to, then obviously that wouldn't be helpul at all. And it may be with most people I see, aren't experiencing psychosis, and it may be that with psychosis, there are more limitations to doing video consultations.
Yes. Thanks, John. Maybe we could go back to picking up some of the questions again.
Yeah, no, I can nip through some of the questions. Yeah, Abigail asks a really interesting one about how significant do you think the lack of mental health services over lockdown have been? And I think they have been significant. And I mean, you probably saw, Abigail, and I mean, you asked your question before I went through that, but one of the factors we found associated with worse outcome in our cohort was difficulties accessing mental health services. So I think we've even got evidence at this stage that lack of mental health services has impacted people. So I think there's the direct effect of not being able to see people as planned, and B, I think there's the waiting lists that have built up for things like psychological therapies because services have been, people haven't been able to see people in the usual way through their waiting lists, and so waiting lists have definitely expanded. And that's why we're looking into these alternative techniques such as guided self-help that can give treatment in a more timely manner to more people. Claire, hi Claire, who's very familiar with guided self-help treatments, asks treatments about, do you think evidence-based treatments for chronic fatigue syndrome might be useful for long COVID? Yeah, and I totally agree with you, Claire. And I mean, you probably know that when I was talking about graded exercise and some of the debate around that I was actually referring to the current draft NICE guidelines with respect to treatment for chronic fatigue syndrome. So there is quite a debate going on. I mean, I think the truth is that there are different lobbies within the world. And again, chronic fatigue syndrome for me is probably quite a heterogeneous, condition. I mean, I think it's called a syndrome correctly because we can't actually determine what the underlying pathological cause of it. And we're probably dealing with a mixture of things. And ultimately, I think that we need to move towards more personalized approaches that actually address the issues that people have got on a personal level. Bronwyn, what direction do you see the research moving next? Well, in mental health, I think it's sort of following people up longitudinally, seeing what the longer term mental health outcomes are of COVID. As I said before, we're still in the midst of it if you think about it. I'm very used to researching traumatic events like a one-off a terrorist attack on something. This is very different, and in my trauma world this is much more akin to flooding, for example. You heard the flooding in the northeast of England, in Somerset in recent years, and the people that have researched that, they found sort of much longer term mental health difficulties that have got got much more of a depressive flavour overall to them than a post-traumatic stress flavour. So that's what I'm expecting to see will come out over time, that we won't get sort of the acute re-experiencing PTSD type symptoms that you would assume to a very short event. So I'd hope that research looking at that, and I think we'll get to learn more about, you know, so-called long COVID, and also, you know, neuropsychiatric issues from people who've experienced COVID themselves. Mirella, is there something like acute and chronic anxiety and depression? It's a really good question, Mirella, and the answer is absolutely yes. We may not label them in those ways, but for me, and I'm quite interested in this, if you look at depression and just call depression, I reckon there's probably at least 10, maybe 20 different types of it, and it's unhelpful on one level to think of depression as a single, you know, diagnosis or condition. We should be definitely looking at individuals, and it goes back to my earlier point about personalizing your treatment for things. I'm a post-traumatic stress disorder researcher and clinician. In recent years, we've now got post-traumatic stress disorder and complex post-traumatic stress disorder. And just that two-pronged divide has made a massive difference to me, and I think to the people that I try and help, you know, thinking there are two different conditions, because you end up treating them in quite different ways at the end of the day. Anne Hawkins, how can you support a dad who wasn't allowed to be present at the birth of the first baby? Yeah, due to both himself and his wife being positive. It's a really good question, Anne, and I think you know, that's a good example of a much wider thing, and I think it sort of feeds into some of my other points about you know, particularly being present at, you know, at funerals and things, and perhaps, you know, other things where you've not been able to have that close one-to-one relationship at the start of life, which allows bondings. I mean, I think a lot of grandparents have been in that situation with children. I definitely look at the individual, discuss it with them. If you feel that there are sort of definite sort of concerns and a pathological response emerging, then I'd encourage that individual to seek help and support. And certainly, you know, in the trauma work that I'm doing now, we see a lot of fathers coming through with issues related to traumas they perceive around the time of birth. I'm not saying that this would be a post-traumatic stress disorder, but it clearly would result in potentially significant adjustment difficulties following a birth. So, you know, definitely take it seriously, and it's something that could cause, I believe, significant distress. How are the resources accessed for Rian? Great question, Rian. Very good question. I mean, we've been putting forward proposals to Welsh Government about what we think would be helpful, and they've been very supportive so far in my field of traumatic stress. And those guided self-help interventions I spoke about, the development of those has been funded by Welsh Government in direct response to COVID-19. And I know other things are going on that are funded by Welsh Government. Ultimately, I know, and I'm talking to others, the plan is to try and move towards funding things where there is good evidence that they do work for people. So kind of funding based on outcomes, if you like, is the goal. Bronwyn, is there a non-direct trauma due to COVID? For example, if there is an increase in domestic abuse, sexual abuse, Bronwyn, I could have planted you in the audience to ask that question, so thank you very much for that one. That is one of the questions that we asked in our survey. We just haven't analysed that yet, but you're absolutely right. And as you know, there are a few studies, I didn't mention them tonight, you know, apologies, time prevented going through everything, that have shown slight increases in domestic violence during COVID. So yeah, I believe it's a real issue. And in fact, part of that argument, I think, convinced Welsh Government to give us funding for the complex PTSD type guided self-help work that we're doing, because that was an argument that we were making on that. Sharon, is there any data on prevalence of PTSD and severity, COVID illness? It's a good question. I've not seen any studies yet, Sharon, that have actually gone into looking at that in detail. That's the sort of research that I strongly believe, well, I know will come out as time goes on. And in fact, with our work, we will be able to start to look at that with our cohorts, although obviously we've got, you know, sort of quite a unique, not a general population cohort. Kai, that's very kind of you. And Rian, that's very kind of you. And yeah, and Harry, that's very kind of you as well. Thank you, James. I've been through all the questions.
Fantastic, John. Yeah, superb presentation, and then a magnificent job of addressing the questions. I think my colleague Karen Edwards would just like to come in briefly to capture some feedback. Karen, are you there?
Yes, yeah, that would be great. Thank you. I'll just share my screen quickly.
Whilst Karen's bringing up her screen, I'd just like to remind everyone that we're back on the 14th of January for Professor Sir Michael Marmot from University College London, who's going to be talking on social justice, health equity and COVID-19. So that's the 14th of January.
Great, okay, thanks. So for those that are still with us, I know may have been with us in previous lectures, just a few questions just to see how you felt about this evening's lecture. So if you can go on your devices to menti.com and use the code given there at the top of the screen, 4261673. And the first question there is, where are you joining us from today? So it's really useful to know where our audience members are coming from. Right, I'll just give you a moment to complete. Good to see somebody. We've got somebody here from outside of the UK. A few from outside of Wales also. Great. Okay, while you're just finishing that one, I'll move on to the next question, which is, have you attended a Science and Health lecture before? Quite a few regulars here, and good to see quite a few new attendees also. Great. Okay, so great, already on this one. Where did you find out about the lecture? It's really useful for us to know, you know, where people hear about these lectures. Quite a few from Twitter and Facebook I see, and Cardiff University events. Okay, just to point out, our Science and Health webpage has always got information on about these kinds of events and activities. Okay, so why did you attend the lecture this evening? You should just select the top 2 reasons. Okay, mostly to be informed. So hopefully you have been. I'm sure you have. So as a result of viewing the lecture, do you think that you might take any further action? I'm glad to see that most of you say your knowledge of the subject matter has improved, and quite a few would like to find out more about the subject. Okay. Right. And then finally, if you could describe the lecture in 3 words. That's really good to see you found it informative, interesting, enlightening, insightful. Great. Thank you. Great, looks good. Okay, so we'll stop sharing there and just hand back to James just to say good evening and thanks to everybody.
Thanks again, John. I hope you found the word cloud there quite gratifying. I think it really reflects how much people have appreciated your presentation this evening. So it just remains for me to provide season's greetings to everyone. Stay safe, and we look forward to seeing you again in the new year. No sta, diolch yn fawr iawn.